shut down my packs. I'm gonna put this over here. Sorry, let me just blow this up here. There we go. Share. All right, so let's switch cases first. This is one of those incidental findings that don't mean anything. It's just really odd. I've seen a lot of coronary anomalies over. Is this not going to let me window it? Oh, that sucks. This is a recon series I made, and it's not going to let me window it, which is really unfortunate. But you know, someone asked me to look at this, and basically they didn't really see a right coronary artery coming off, and you can see that there is a right little tiny RCA, and they thought it was coming interarterially, but if you actually follow it, it kind of is, but it's actually originating. Let me see if I can load this up in at least the 3D. It's not going to let me, son of a bitch. All right. Anyways, you can see here that it's actually coming off the septal. So the first septal LAD, it's actually probably coursing intramural in the wall of the PA. It's hard to tell, but it's definitely coursing in the septum of the LV, and it's coming through and actually supplying that small RCA. So it's actually a very small RCA from a septal branch, which is weird. And then on top of that, there's this strange venous drainage anomaly where the associated corresponding vein, instead of draining inferiorly where it should into the inferior interventricular vein, usually, there's actually this anomalous venous drainage that courses pre-pulmonic here. First, I thought it might be an ALCAPA, but it's not. It doesn't actually connect. And I'm sorry, ARCAPA. And remember that ARCAPA, A, there'd be 2 arterial supplies, and B, the vessel would be absolutely massive, much bigger than this. And then on top of that, you follow this thing, it comes around, it goes up, it goes down, and eventually you can follow it going all the way down and then dumping here into the anterior interventricular vein or some tributary of it. And I'll send over the regular recons. I did these because thought it would save time, but it's actually not making it look not as good as it usually does. But this is just a weird arterial anomaly. Doesn't mean anything. The patient has a very huge left-sided circulation, which supplies everything. This is, 1 second.
Hey Seth, how old was that patient?
60. She was here for an AFib study.
Do you think it could be like a chronic total occlusion of the RCA, and maybe that's just a collateral? Like, do you see an RCA ostium at all?
Do I see an RCA? No, I think it's coming. Oh, do I think there's a chronic total occlusion? No, I don't see any. There's no real ostium here at all. I know what you're saying. I don't. It almost looks like, you know, I have seen one case of an interrupted left main. Usually that's fatal. It could theoretically be an interrupted RCA, where you actually have no ostium. That's actually an interesting thought, where you actually have no ostium of the vessel. You actually have a maldevelopment or early occlusion prenatally in utero, where you actually get, usually it's fatal, but occasionally people survive. And but the thing that goes against that is that I didn't show it, and I can show it later in the thing after I anonymize it. Her function, biventricular function, is 100% normal. So, and she has no evidence of prior infarct. So it is possible that she had, you know, you can see that it should almost be kind of arising from here, but it's not. There is a little SA nodal branch. Maybe that it's an interrupted right coronary artery, which, I mean, theoretically can happen, but it's just weird because every patient I've seen that lives with an interrupted artery has evidence of prior infarct. But maybe the fact that she's got a very large left dominant system makes up for that. But, you know, she's a young patient. She has her coronaries are 100, you know, this is not calcium, this is artifact. Her coronaries are 100% clean. Yeah, so, but that's a good thought. This is a patient. When I saw the follow-up study, I was very concerned because I read the original study and I was kind of took a sigh of relief when I went back and read or someone showed me the follow-up. So this is a patient with an endocarditis. You can see that aortic valve is not very happy. She's an older woman. She's not I don't see a history of drug use. I think she just had a valve replacement, got infected. You can see there's an abscess around the aortic root, a lot of fluid. It's pushing. You know, it can be hard to differentiate, especially on early arterial phase of contrast, an abscess from just fluid around the, you know, in the transverse sinus and superior pericardial recess. But whenever I see it pushing and deforming the left atrium like that, I think to me that's a good clue that this is a mass filling process and not simply just some fluid around there. Anyway, so I saw the follow-up and I was like, I went back and took a quick look at the left main, because here is the open as 3D. So she went to surgery and I was like, what the hell happened in surgery? Because just scrolling through this thing, the first thing that pops in my eye is that that most of the myocardium is not enhancing. And very nicely, if anyone wants to see what a left main territory infarct looks like, that is it. And you can see the right coronary artery. That's just a little, what do you call it? Not diverticulum, like a little blanking.
Crypt.
Crypt. Thank you. Yeah, so if we want to see what's the left main, unfortunately she had a big RCA, so she only lost about 60% of her heart. But I went back and like first thing I was like, oh crap, and then looked at the coronary, and this is not an interrupted artery. There is an occluded left main. Called the surgeon, he said, yeah, it was like that when we opened her up to replace the aortic valve. So I was like, okay. And they did bypass her because they saw that it was occluded when they went in and did the surgery, but not good. And still has some fluid around the aortic root, but that's not good. And then lastly, this is, I don't know if I showed this case. It's like one of those cases where it was old, but we had to follow up and I never know if I showed it. So this is a patient that came in. So she had a car accident a few years ago, went, had a CT, chest and pelvis, and was diagnosed as having lymphoma based on the CT. And she, second, put that on. Hold on one second, I'm sorry. I need to call you back. Okay, thanks. And she had a biopsy of this, which came back as what I think most of us know it is. But she came here for basically a sternotomy and resection of this mass. And I was like, whoa, this is just, it's just thymus. What's interesting about it is that it goes into kind of between the aorta and pulmonary, or the SVC and aorta there, kind of dives deep. And on the outside, they also got a PET, which doesn't really do much in general, as I think all of us know. PETs are not good for, I think they thought it was I think they thought it was lymphoma. But anyways, PETs are not the best for assessing the difference between low-grade thymoma or thymic hyperplasia, because both are hot. Obviously this doesn't look anything like a thymoma, but it's really interesting. You can see this thymic tissue invaginating, and it is pronounced invaginating between the aorta and SVC. And she had a fall, and the surgeon came to me. I said, it's just pronounced thymic hyperplasia, but I don't think this is the the thymic hyperplasia you get off of chemotherapy. I think this is I can't remember, it's the lymphoid hyperplasia. You can still, and this is the follow-up where you can still see it diving in. And we actually have an MRI which shows it saturates out as well. But it's not a very good quality, and I was embarrassed to show it. But this was, I think, a case of, is it the lymphoid hyperplasia, the one that's associated with future development of like Hashimoto's and Graves' disease and myasthenia gravis. There's one that's like the true hyperplasia.
That's the one that's associated with autoimmune diseases, the lymphoid hyperplasia. You know, it's interesting. The only paper I've ever found that made a distinction between the two on imaging was measuring the mean attenuation, because with hyperplasia, you just have more tissue. With the lymphoid hyperplasia, because you have the germinal centers and the follicles, you get denser tissue. But it, you know, it was one small study.
Yeah, I just assumed that this was the true hyper, just because how big and prominent it was. And she wasn't. She was a, you know, she's a 35-year-old woman. She's not on any medication. 30-year-old woman, and just how pronounced. I just assumed it wasn't the kind of. She had no stressors in her life. I mean, she had an auto accident when she came in. I don't think that would cause a massive thing that stayed unchanged, but I just assumed that it was probably lymphoid hyperplasia versus the kind of reactive hyperplasia. I may be wrong, but anyways, they told her she may develop some autoimmune disease in the future, or keeping an eye on her. But I just had never seen it dive between the SVC and the aorta like that. But it also makes sense when they biopsied and they just got benign thymic tissue back when they put a needle in it on the outside place. But those are my cases.
Great.
Excellent.
When they biopsied, was it lymphoid hyperplasia or was it ordinary?
You know what? That's a very good question. It came from the outside. The only thing that we did here was this follow-up CT, and I from the notes I read, it just said outside biopsy showed benign thymic tissue. So this is the only CT we got here. We have the MR too, but again, it's really bad. I'll check the notes, Dave. That's a very, very good question to see if they differentiated.
Yeah, I'm still surprised. I mean, I probably see it now once a year. We get referred to mediastinal mass that's just normal thymus. And I don't know about you guys, but I see it, especially in females, up into the 40s sometimes, not to this extent, but still residual tissue. And in males, a little bit younger.
Yeah, absolutely. Absolutely.
All right.
Jeff, I have one cute case apropos of previous weeks.
Okay, let's see if I can find you on the list. There we go. All right, you should be able to share your screen now, David. Yes.
Okay. So if you can see this radiograph, it does show a mass here. This person has nodular sclerosing Hodgkin's disease. It does have this big mass here, which looks like could well be Hodgkin's disease, and it fits that way on CT. But let me show you the CT, and you will first we'll look at the lateral, and you see there's another nodule down here that's kind of smooth. Maybe we're not sure. So here's our central mass, which I think fits with the Hodgkin's disease, but there are these other nodules floating around. And let me show you one of those nodules. So we've got some nodules down here, and we've got this nodule here. And so this lingular nodule was biopsied, and they got back non-caseating granulomas. And then they made a diagnosis of syphilis. So these are actually syphilitic nodules in the lung. And this is when you have tumor-like manifestations of syphilis, it's called gumma. So these are gummas. Gummas used to occur in the abdomen in the days of syphilis. Here are gummas in the lung. So I just wanted to round out our recent syphilis experience here. I showed this case back in 2016, by the way.
I was going to jokingly say syphilis just based on what you've been showing. I actually think that truly be syphilis. That's great.
Okay.
So is there endemic syphilis in Seattle?
Yes, every 40 years we have one case, so that constitutes an outbreak. You know, there's a lot of syphilis. It waxes and wanes, you know, in these sexually active communities here. And so I think 2 years ago they were saying that there's another rise in syphilis, you know, particularly I think in the gay population. So people let down their guard, you know, their big concern goes to HIV and stuff like that, and then people lose track of syphilis and other sexually transmitted diseases that are out there. So they come and go in this population. I haven't seen that many cases, frankly. Okay, that's all I wanted to show. Gummas.
All right, nice.
Cool.
So we've seen the full spectrum of thoracic syphilis, I think, except I can't remember. There's some congenital things. Do they get like a sternal abnormality or something?
Uh,
I can never remember. We don't see it. Okay. Who would like to go next?
I can show a couple.
All right. There you go.
Okay. You see a radiograph?
Good.
Yeah, this is just a quick, fun case, getting away from COVID stuff. This is an older patient. You can see he comes in with a left-sided hydropneumothorax. You can see the pneumothorax and a little line from the pleural effusion. And he has underlying lung disease. He's a little busy at the bases, some fibrosis, and his lung volumes are preserved. I think he's 80. So you wonder, does he have some sort of combination of emphysema and underlying fibrosis? So the radiograph is actually after the CT. This was a spontaneous pneumothorax, unknown at the time of the CT, and that's one of the reasons I'm showing it. It's not a new diagnosis. It's just kind of fun to see this, especially when I show you the expiratory. He has upper lobe predominant central lobular emphysema, and then he certainly has fibrosis, and this is a UIP pattern at the bases. So he has basal peripheral predominant traction, some honeycombing. And so, we avoid the term combined pulmonary fibrosis and emphysema just because it's not as descriptive as saying that this patient has a UIP pattern and was diagnosed clinically with IPF in addition to his emphysema. But I thought this was kind of fun. And David, I think you in particular, with your love of pneumothoraces, and he does have a little bit of mediastinal rotation, obviously not indicative of tension, but on our dynamic expiratory, it was just kind of fun to watch, especially in these images, to see how much more the left upper lobe collapses during dynamic expiration as opposed to the rest of the lung. And I don't like right in here in particular in the lingula. And I guess it's just because you've lost the elastic recoil as the thorax contracts that, it's I don't know if anyone wants to postulate on the physics of this, but I would just assume it's because you have the air maintaining this space and then just forcing this lung to collapse more than the rest of the lung, as well as the loss of adhesion here. But I thought this was kind of cute.
So Travis, have you seen this before when the collapse goes preferentially to an upper lobe, or is this the first time?
Oh, like this?
Yeah.
I don't know. I mean, I've never seen I don't remember a pneumothorax on a dynamic expiratory image. That's why I was showing this, just showing how this lung collapses more like this and just trying to speculate why.
I've never.
I wonder if in this case there may be some adhesions or something like that, or some pleural thickening that keeps the lower lobe stuck to the lateral chest wall and keeps it from collapsing as it would like. Maybe, but it doesn't.
Yeah.
It doesn't look that irregular the way that usually the lung is irregular and there's atelectasis associated with that sort of adhesion. I'm not sure we really have.
I just thought. I mean, I guess
That's
it's just since he's exhaling, this air doesn't have anywhere to go, so it's just forcing that lung to collapse more than than the rest of it. The left lower lobe is still collapsing too. You can see the fissure deforming, but I just thought this was kind of a cute dynamic series.
But Travis, am I allowed to lecture now on the diagnosis of tension pneumothorax?
Oh, please. And hopefully my terminology on rotation of the mediastinum is to your liking too.
No, I love that. The thing is that there are no radiographic signs that are specific for tension, and that the strict diagnosis of tension is that atmospheric pressure is exceeded in the pleural space, and therefore you benefit the patient by making a hole in the chest wall. Normally it's bad to make a hole in the chest wall because you get a pneumothorax, but if the pressure is higher than atmospheric in this pneumothorax, if it's true tension pneumothorax, then air comes gushing out and the patient feels better. So the diagnosis of tension goes with the advisability of making a hole in the chest wall. So as soon as you introduce any pneumothorax, the mediastinum begins to shift away from that side. It doesn't require tension. Suddenly atmospheric pressure is reached, and now it's time to shift the mediastinum. It's not a step function like that. Mm-hmm. It's gradual. So the more air you put into a pneumothorax, the more mediastinal shift you get. mediastinal shift does not equal tension. End of lecture. Thank you.
I thought you prefer the word rotation over shift.
Well, shift
the
is
mediastinum.
fine, whatever you like in that
Okay.
regard. Just don't take it as an indication of tension. Thank you.
Yeah. All right. Now this one, this is both an interesting case the follow-up so far has not been very satisfying to me. So this is a radiograph I saw last week, and this patient, as you can see, has a mechanical bileaflet aortic valve. He has a stent in the arch and descending aorta. And it was very nice to have a prior to compare to. Let's see if we can get these both windowed. So I saw this and then saw the prior and let you look for a second. If anyone wants to comment on the change that they see. This one's from like a year ago, I think.
There's more opacity lateral to that stent.
Yep. Yeah, and that's
distal.
exactly, yeah, that's what I saw. So I went digging in the chart. And this was actually a pre-TE, transesophageal echo radiograph. This patient had just been admitted with bacteremia and they were worried about endocarditis. So I called them and I said, I don't think this is just projectional. I wonder if there's increasing fluid or something in the mediastinum around this. So let's see, that's the old CT. I think this is the one, yeah. So actually, I'll show his old CT too. So 2019, you can see there's a little bit of fluid, and this is kind of like what Seth was talking about with his case. There's a little bit of this peri-graft fluid here, and it extends up to the arch. So he had a type A dissection repair with an ascending replacement. You can see he's had a debranched arch that's been reimplanted here on the ascending aortic graft. But this is certainly worsening, increasing fluid that corresponds to this. And you can see it extends up along the arch as I show you here. So I thought, I told them this graft is almost certainly infected now. There's enhancement. In fact, I have a delay. There's a little bit of inflammatory stranding. I don't see anything. He has some reactive nodes that have increased, and I didn't see anything along this aortic valve either, or the mitral valve. I don't see a ring, abscess, or anything. I think the surgeon still, they are reluctant to believe these. The patient had 3 blood cultures that were positive, and the surgeon's like, well, it doesn't really look that much different than last year, and tried my best to persuade them. But yesterday they got an Indian labeled white blood cell scan, and I'm curious what everyone's experience with these are, because they're, the TEE has since been done and is negative, so he doesn't have it doesn't look like he has anything involving that valve. And moreover, with mechanical valves, you would expect something involving the ring rather than something involving the valve leaflet itself. But unfortunately, there's absolutely nothing here in this freaking white blood cell scan that was done yesterday. So I don't know what the hell to make of this now. I don't know what the performance of this is. I still think that this is the best explanation for his bacteremia. They're not going to reoperate on him at this point. He is going to be on antibiotics for quite a while, but just curious if anyone else has any thoughts.
Hey, Travis, can you scroll to the right atrium on that CT?
Yeah.
Right there. Yeah. Does it seem to you like it's originating from right there, that fluid? From right where that's.
I think this is. I don't know what this is that was there. Yeah, I don't know if they cannulated the atrium there or whatever. He's had
very often they cannulate.
That's the right atrial cannula. Like,
yeah.
Fluid dripping down, hanging down from the aorta.
I wonder if this could be just granulation tissue that's enhancing around some fluid.
Well, except that it's increased,
Right.
from priors, and he's got all of these new nodes surrounding there. It's confined to the graft because they kind of did like a staged elephant trunk repair where they dropped the stent in here.
Yeah.
And it's just like, I mean, he's bacteremic, and he's got, and that's,
it looks like normal for sure. Yeah.
I was just disappointed in this white blood cell scan, and I don't know what to make of it.
Why are the bone? I don't remember nukes at all. I don't know why the bones are so bright with the white blood cell scan, and why the
it's the reticuloendothelial system, right? Because you're just basically tagging white cells. So I don't know. I was very happy with myself on the radiograph, and now I'm just, you know, now the fact that I haven't been confirmed, I'm slightly perturbed and disappointed.
Travis, you might talk to the nukes about whether they have problems with white cell scans. Sometimes maybe the white cells died and they weren't active, and they were just phagocytosed by the reticuloendothelial system rather than going to infection. So I'll bet you they have problems with that. Anytime you're depending on cell function with a scan like that, you could have problems.
Yeah, because when I was prepping this case to show it this morning, I didn't even know that it had been done until I was looking through the chart. So I haven't had a chance to research the white blood cell scan more. But,
yeah, it's concerning.
All right, well, Jeff, I will stop there.
All right. Who else has cases this week?
I can show the case that I sent out this morning just to get additional comments on it if
Sure.
folks want to. So here it is now. The first that I came across this was on the more recent. So I don't do cardiac imaging, so if there are findings that I don't mention that are relevant to this discussion, certainly mention them. But there's a history of a L-loop transposition and pulmonary atresia, VSD, and the person has had a Glenn shunt as well as a Fontan. So that's sort of that context. So here we have the Glenn up here, and then we have the Fontan between IVC directly outside of the atrium to that right pulmonary artery. And I'm not sure why this was done, but there is planned transplantation being considered. So I think I understand why there's contrast medium that looks like this in that right pulmonary artery, because we have contrast coming from above. We have non-opacified blood coming from the IVC. So we have that mixing phenomenon there. And then the person's got an epicardial surface pacer electrodes. And this apparently was put in at some point in the past to occlude a mediastinal vessel. So that's I guess it's an implantso or some kind of vascular plug. So I saw all that, but then I was really intrigued by seeing this down here. So I looked at that for a bunch, and then I found an older CT, so I started looking at that. So this CT is from last year. And let me just show you, in the interest of time, the more delayed phase of this abdominal CT. And I think what we have here is definitely varices, and Travis mentioned that maybe one of these vessels is coming from the left renal vein superiorly, but we have those abnormal vessels, then paraesophageal vessels, and I think for sure that these are communicating directly with that left inferior pulmonary vein right there.
Mm-hmm.
So Seth mentioned the possibility of cirrhosis, kind of passive as a consequence of long-standing right atrial hypertension in this context. So the liver disease, and then these collateral vessels and varices, some of which are going directly into that left inferior pulmonary vein, which does happen. Does everyone agree, or any additional thoughts?
You see this, you know, this is a big one. I've seen it. I don't know. We do a lot of, to my chagrin, Fontan, you know, basically right heart bypass, Fontan Glenn imaging, and this is not that uncommon when someone gets really bad cirrhotic liver disease. That I've seen them. It's just the path of least resistance is the left heart versus the right heart, because the pressures in the left atrium are less than that in the right atrium. Yeah.
So Howard, do we know if the man had cirrhosis here. He doesn't have a big spleen. Doesn't look like portal hypertension.
Not in that sense. And this is a young person,
But his liver looks,
19-year-old female. But the liver looks that way, doesn't it?
No.
So this is a young lady being worked up for transplantation.
I think that makes sense then.
Just so
Yeah.
happens to have that communication.
and those, and similarly, you also get systemic venous SVC, brachiocephalic vessels that also drain into the pulmonary veins, and that's what they embolized with that when you saw that coil. So same underlying reason, the pressures in the Glenn circuit are so high because of the pulmonary pressures get high, that you basically get systemic venous collaterals that drain into the left atrium instead of going into the Glenn and into the lungs, causing a shunt, and they can be quite pronounced. So we scan these patients all the time looking for someone that has desaturation or issues, looking for these ones that they can embolize. And a lot of times you see them off the brachiocephalic, but they can come off anywhere, internal mammary veins. So yeah.
So Seth, where do those vessels go, and what are the effects of those vessels?
So they're basically bypassing the pulmonary circulation. So basically you're getting systemic venous shunt, so brachiocephalic vein, SVC, and they're coursing through the mediastinum, and then they'll drain into a pulmonary vein. So they're basically unoxygenated systemic blood bypassing the pulmonary circulation and going right back to the left heart. And
just because the right-sided pressures are so high?
They're so high, and it's just the path, at least. I mean, I'm sure there's a much more detailed, complex understanding of why it happens, but to me, it's just the basic concept of the pressures in the right heart or the pulmonary circulation are so high because these patients develop pulmonary hypertension after a while because you're directly feeding blood into the pulmonary arteries, and this is just what happens to them. And then these kind of shunts develop almost like pop-off valves, at least to my understanding.
So they bypass the lungs, they go to the left side of the heart, and
Yeah.
some of them need to be basically dealt with because of hemodynamic and oxygenation effects and so on. So they may embolize and or occlude some of them.
Yeah.
Now, Howard, on that abdominal CT with delayed imaging,
Yes.
did IVC eventually opacify, or is there an IVC thrombosis problem too?
So this is,
Does it?
this is the delay. I think that's okay.
I think it's okay.
And this is
What was the question about the portal vein?
Well, about whether the IVC was
Occluded.
was obstructed too, and that was, helping create this liver disease. It looks as if it's opacifying here.
Yeah.
I
You
think
can
so.
get some pretty high pressures in that Fontan circuit. It's pretty surprising, and that's the same reason why they get such bad liver disease. I mean, this is all due to elevated right-sided pressures.
So I've got a really good case that a colleague told me about today, but I'm not ready to show it yet. But it has to do with IVC, liver disease, occlusion of the IVC, and collateral. So wait for that case because it's a really interesting one, and I'll show it next week. Okay, Jeff.
All right, thanks. Let's see, Peter or Brian?
I don't have one.
I'm sorry. Which one are you?
Brian, do you have any? You can go.
I don't have one.
Okay, I have one.
Okay. Let's see. There we go.
Okay, can you guys see my radiograph? Okay, so this is a case showed to me by Art Stillman. So we have a big heart. there's redistribution of the pulmonary blood flow. You can see large vessels up here. And then some more subtle findings. Also, there's a double density sign here. But some other subtle findings, rib notching on the posterior ribs. And some right there also. And then the number 3 sign here. I'll show the CT. Here is the aorta. So this is unrepaired coarctation, and then you can see all the other sequelae of that with the collateral vessels, large intercostal collaterals, or intercostal collaterals here, the rib notching. Aortic valve looks okay. And then very large right atrium. So open the chart on this patient to see she's an immigrant, non-English speaking Hispanic patient. And was wondering why she has the left atrial enlargement. If you notice here also, she has these hypertrophied pap muscles. So she has a reported history of rheumatic heart disease, and her valve, her mitral valve is also both stenotic and regurgitant. And you can see these pap muscles here kind of extend all the way to the almost completely to the valves, or chordae tendineae are completely tethered. So this is unrepaired aortic coarct and rheumatic heart disease.
Boy.
That's all I have.
All right. Wow. It's Congenital Heart Day. All right. Let's see. I think we got everybody. Okay, I can show a few here. Let's see. Okay, so let's start with this case. So this is a 49-year-old male who presented with cough, shortness of breath, and a low-grade fever. And I don't know, this was done for PE. There was no radiograph done. And he was a COVID rule out as well, which is, that wasn't their primary, it was one of their things, but I don't know why. He had no exposures. And we have a relatively low prevalence here, but you can see he's got these ground glass opacities, but unlike with what we're seeing with organizing pneumonia, with COVID and peripheral distribution, these are much more airway centric and actually are quite bronchiolocentric, both lungs here. And so initially he was told he didn't do anything, just no drugs or anything like that. But then I talked to the pulmonologist who was consulted, and indeed he is a vapor. And he vapes marijuana. So, the infectious workout has been negative. So this is another, presumably EVALI. I mean, it meets the criteria. It's a little bit different than what we've seen, but Travis, I think it looks like some of your synthetic marijuana cases you've shown where it's more airway centric.
Yeah, and is he someone that's been vaping more in his under stay in place orders?
That's unclear, but I would presume it's easier to vape when you're staying in place, because you just no smoking signs everywhere. But it's interesting too. We've seen a big decrease because I think one of the much of the culprit was contaminated stuff bought on the black market, but you'd figure right now with social distancing, there's not much of a black market. And I think the vape shops were deemed essential businesses, so they didn't close. But yeah, but I've seen two EVALI cases present, mimicking COVID, in that they present with an acute respiratory illness with a fever.
Yeah.
Well, I think Seth has seen a couple. We had one that I showed a couple of weeks ago, and the issue is that, you have to, like you pointed out, Jeff, with the airway centered nodules, that it's like, that's not a typical look of COVID.
Right.
And moreover, they need to give these patients steroids. The guy we had was intubated, and he had 4 negative COVIDs. They still wanted to bronch him to do another COVID. And then you know, we finally convinced them, and we were like, no, this is almost certainly due to his vaping. And so they started steroids, and he was extubated the next day and went home a couple days later.
Yeah. I believe this guy was actually discharged as, you know, to follow up with pulmonary. I think his oxygen saturations were good enough. But
Yeah.
yeah, it's a lot easier now that I think most major centers in the US, you have pretty rapid turnaround on the COVID test. So by the time the whole ED workup is done, we usually have an answer.
Yeah.
And flu.
Yeah, Costa was saying at Barnes Jewish now, they have like a 30-minute turnaround time on their COVID tests.
Yeah.
They have a rapid test.
We do too, actually. 30, the max is like an hour. Usually it's between 20 and 30 minutes. But it's only certain, it's like one that you can only do 1,000 tests a day, and it's one test at a time.
So yeah, I mean, it's interesting because, you know, we had a like sort of the cases sort of disappeared. You know, there was a few trickling in February, March, and then it seems like we've seen a few more lately. And I wonder if it's just people have had more opportunity.
Yeah. I think so.
So this is an interesting case. I know what questions Dave is going to ask me, so I've made sure to know the answer or not. So this is a patient that has a history of a vocal cord squamous cell carcinoma, and this was just done as a MET survey, and had these nodules. These were new. You can see they're small. Some of them are more peripheral, and then this one's a little bit bigger. And they have these fuzzy margins, and they're kind of clustering together. Those are predominantly in the upper lobe on the right there. So they don't look like your typical METs at all. I mean, there's some bigger ones down here. But, you know, squamous cell METs are usually pretty sharply marginated. They may or may not, you know, they distort the lung and they can cavitate. These look, you know, more inflammatory, but, you know, I mean, common things being common. You know, you wonder about aspiration always in these head and neck cancer patients because of radiation and altered swallowing function. He's got little stuff in his esophagus pooling, but nothing horrible. So he got a full infectious workup. I think they bronched him. But anyway, the interesting, this ended up growing out of fungus. Or not growing out, but having PCR, an antibody or antigen positive for Cryptococcus. You know, as far as I know, he's not immune suppressed. Unfortunately, I can't tell you if it's Gaddii or neoformans because it's just the antigen test. So the culture didn't grow it out, but he was treated with antifungals, and I didn't save the follow-up scan, but it showed them getting a lot better. Mm-hmm. So, you know, we always think of crypto as being sort of an opportunistic infection, but it does affect a small number of adults, and, you know, maybe if they're deconditioned or something. But I think, you know, always jumping the gun on METs, just keep in mind, you know, they're common, and in a patient with a cancer, it's not an unreasonable thought, but especially when they don't have that, when they have sort of this fuzzy look to them, especially for squames. This is not a typical squamous appearance to me with the halo around it. So you have to think about other things.
I think what's striking about this case is how peripheral these lesions are. Usually the fungal lesions are more central.
Yeah.
I was even thinking about possibly of septic emboli, given how many of these things are against the periphery.
Histo seems to be very peripheral. You tend to see the dominant nodule in the lung periphery and then the draining clusters along the bronchovascular bundle. But yeah, you're absolutely right, David. You can see these on the lung periphery. All right. Let's see. This is a crazy case. Chris Francois shared this with me. This is a 60-year-old female who I presume presented with some shortness of breath and looks like this. So she's got these crazy looking vessels around and these huge coronary arteries, you know, all these additional branches. And you can see the left ventricle looks a little bit big there. But what she actually has is this. Mm-hmm. Here's the pulmonary artery, and you can see this pulmonary coronary artery coming right off of it. So this is an ALCAPA, but presenting it in late 60s. You know, it looks like she's aspirating. Maybe even a little bit of lipoid aspiration or something down there. But yeah, I've never seen one this late, and how she made it this far, I don't know. Any thoughts?
Yeah, I showed one a few years ago in an adult with an undiagnosed ALCAPA, and it was somebody that was so high performing he had run a marathon.
That's crazy. I don't think she's running marathons, but I could be wrong.
No, but it's baffling.
Yeah.
And then you can see here the left apex is, the left ventricle is all pouched out.
Yeah.
Not doing very well. And what's always fascinating to me in these older patients to develop it are these dramatic hypertrophied septal feeders that, and also that feed all these, and you could follow them out and you almost wonder if they fistulized directly with the chamber because they're so pronounced.
These right here, right?
Yeah, all those things. And if you scroll up, it looks like there's just nodular enhancement everywhere. And you see that with these ALCAPA cases. Presumably just
LAD.
Yeah. But it's a very interesting, collateral pathway.
Here's the angio, just, there's the right coronary system. You can see it looping back around to the left.
And filling the PA, it's great.
Yeah. And then I think they don't always come across in the right order. I wonder if they did a ventriculogram. Let's see. Let's see what they're doing there. Anyway, you guys can look at the angio, but that's just crazy case. All right. And then here's just something you guys on the West Coast see a lot, but we don't see so much. But this is a young guy who presented with a cough and got a chest radiograph and then had this cavitary thing and this nodule in the left apex, as well as the second cavity and a cluster of nodules. And, we're more likely to see TB than cocci. It's very rare for histo to cavitate. It can, but it typically doesn't. And so it turns out that with the right history, of course, this guy had been out west, I think specifically in Arizona. So this is known cocci. I'll show the radiograph here as well. But yeah, it's hiding up in here, very subtle. There's another one up in there. But we do see it every so often, and I always try to remind my trainees of it. That especially if you don't have the history, but it often will present. It looks a lot like histo or even TB, but these cavities are more common with cocci. I can't remember the percentage. It was like 10 or 15, and this little calcification in there should be a little clue too. It's probably granulomatous, and just to not write it off as a cause. Now we'll probably see a lot less for the next 18 or 24 months, but it does creep in. Usually when people come back in May. All right, and I can't remember if I think I showed that case already, so I'll stop there. Well, here's one I may not have shown. This was this is a transplant patient, heart transplant patient, presented with a cough and has some nodules. So PTLD infection, the usual suspects. And this is a pathogen we show a lot in this conference, but I think it's one that I think a lot of people forget. And so when I see a lot of nodules like this, I always think of fungus, just, because we live in an endemic area, but there is one bacterium that, in my experience, always images like a fungus, and that's Nocardia. And so, it can present as larger masses, it can do consolidation, but multiple round nodules, to me, I would think of Cryptococcus, Nocardia is a big one. And then, of course, endemic fungi here. But those tend to be more miliary in our transplant patients, miliary histo, miliary blasto, and then miliary cocci if they've traveled. But larger nodules, I tend to favor Cryptococcus and then nocardiosis. But this was quite a burden of nodules, a fairly large one as well.
The large number goes nicely with Nocardia too, as opposed to, say, Aspergillus, which you only a couple of lesions usually. When you get this many, you start thinking about Nocardia. And another consideration for multiple fungal nodules is, let's see, it'll come back to me. I'll get you the specific species of that.
It's clearly not a memorable one.
No.
Yeah. But it's interesting because Nocardia, the primary treatment is sulfa drug, is Bactrim, and patients who are pneumocystis prophylaxis is one of the reasons we don't see a lot of Nocardia. But as these transplants have matured, they often are able to back off on a lot of the immune suppression, and more importantly, they tend to stop the Bactrim prophylaxis. So you typically see it later in the transplant period, has been my experience. But it's another one of these great mimickers. But the little what I always tell the residents and students is it's a fungus that thinks it's a bacterium that thinks it's a fungus with respect to imaging, because it looks a lot more like fungus than it ever does a bacterial pneumonia.
Interesting.
Okay.
Hey Jeff, can you do my screen real quick?
Yeah. Let me find them. Let's see, I got to stop sharing mine. And then, there we go, and I'll make you the presenter. All right, you should be good to go.
I know we already showed it, but this is just a better recon showing the RCA kind of coming off, or at least supplied by the septal here and that thing dying out. And I don't know if it was Peter who brought up the idea of a occluded RCA. I mean, it's possible. The function is quite good throughout. I mean, the ventricular function's excellent. She has no disease anywhere. And I have to say, in the one case I have of a interrupted artery, there is clearly a area, or in most areas where you have a, chronically occluded, you can make out the fact that there's a vessel coming off somewhere. And the one case I had that made me look up the history because it looked like interrupted, there just was no vessel. In here, there's just no inkling of an RCA to be found. There is this little thing. So maybe it was interrupted. I don't think it was a chronic occlusion, just given the fact that she has no disease anywhere else. But that was just a nice kind of just view of that septal branch. Anyways, weird case.
Okay, Jeff, the fungus with multiple nodules, lots of nodules, is Candida glabrata. Not albicans, but glabrata is the one that often has lots of lung lesions.
Okay. I think I've only seen that once or twice, but okay, good to know. All right. Well, unless anybody else has anything, I think we'll wrap up for the week.
Thank you.
All right.
Thanks, guys.
Great,
Take care, everybody.
Take care.